The fact is that the annual number of transplants has quadrupled in the past decade for sickle cell transplant. Vigilance must be maintained all the steps of the process because the side effects of transplant could be worse than sickle cell disease.
A lot of things that have to be considered, that's for sure.
Yeah, it takes a village, basically. It's so much fun to have a parent come back and say, I can't believe they don't have any pain anymore. You can just feel their energy, and it's just so exciting.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Ellen Olson, bone marrow transplant pediatric nurse practitioner at Children's Healthcare of Atlanta Aflac Cancer and Blood Disorders Service in Emory University's Department of Pediatrics in Georgia, and member of the Metro Atlanta ONS Chapter, to discuss stem cell transplantation as a treatment option for pediatric sickle cell disease. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for talking with us today, Ellen.
Thanks for inviting me, Stephanie.
To start us off, why don't you tell us a little bit about pediatric sickle cell disease, its complications, and how it is diagnosed?
Sickle cell disease is an autosomal recessive disease in which the red blood cells become a crescent shape and impede blood flow, resulting in pain and organ damage. Typically, it's diagnosed through newborn genetic screening performed at birth. Once a diagnosis is made, the baby is typically referred to a pediatric hematologist who specializes in sickle cell disease. Usually this care is only at a major medical center.
Ellen, is that something that is done directly after they're born, or is it something that kind of prompts the pediatrician to do the testing?
No, in every state in the country, it's a requirement at birth to do screening for certain genetic diseases, and sickle cell disease is one of these.
Okay, thank you. I didn't know that I knew that for sure, so that's good information to know.
You're welcome.
So are there specific patient populations that are at increased risk for pediatric sickle cell disease?
Yes. Typically, people at risk for sickle cell disease are of African descent, also Hispanics from Central South America, and people from the Mideast, Asia, India, or of Mediterranean descent.
So definitely a wide variety of backgrounds that have this genetic disorder that might show up.
Yes.
So if this is something that they screen for at birth and you find out that a baby is positive, what would be the next step as far as how do the pediatric patients present with symptoms of sickle cell disease?
It's not uncommon for infants 4 to 6 months old to start to show symptoms of sickle cell disease. The infant may show up in the emergency room or the clinic with fevers or hand swelling and pain. Sickle cell disease basically affects every organ in the body because the sickle cells cause damage and affect organ function. Pain, also known as vaso-occlusive crisis, is a well-known complication of sickle cell disease. Other major complications include acute chest syndrome, infections, splenic sequestration, and stroke. Strokes can leave these individuals physically and mentally devastated for a lifetime. Unfortunately, these individuals spend prolonged time in the hospitals including the intensive care unit for management of these symptoms. Overall, there's a reduced quality of life for these individuals with this chronic illness.
That's a lot for a new parent to deal with all of those potential symptoms. And, you're just learning how to deal with your new baby and then adding on all these other potential things that might come up that you just don't know how to deal with or what is going on really.
Yes, and definitely it's challenging because this is a genetic disease. So sometimes there may be other children in the family who have it, as well as extended family relatives.
That's true. So what would the typical workup of a new patient with a diagnosis of sickle cell disease be?
Well, in addition to the genetic testing that they have at birth, they would have a hemoglobin electrophoresis done, which would identify which abnormality they have of hemoglobin in sickle cell disease. And then a comprehensive family history is completed, as well as additional blood and organ tests. These are all usually performed at a comprehensive sickle cell disease center.
Once these kids have been diagnosed, do they have their symptoms? Do they kind of wax and wane as far as the symptoms go with them? Or is this something that immediate treatment is needed for?
Sometimes wax and wane. Some have more complications and issues than others. But basically, once they're diagnosed, we try to have preventive care implemented. It's very important in avoiding the potentially devastating complications of sickle cell disease. And the preventive care includes giving penicillin prophylaxis, folic acid, hydroxyurea, and making sure they have their vaccinations. Preventive care is obtained through education, which is vital in preventing complications. And it includes instructions on maintaining hydration daily, avoiding getting dehydrated, being very compliant with your medicines, avoiding extremes in temperature, and calling for fever or other signs and symptoms of infection, call for pain or other concerns. It's not uncommon to see many admits for sickle cell pain complications during periods of extreme cold or extreme heat. Other treatments include chronic transfusions of red blood cells to treat their anemia, other medications and supportive care, as well as investigational studies. With chronic transfusions, they develop iron overload from the transfusions, and they're treated with iron chelators or phlebotomy, requiring even more clinic visits. Transplant is the only known cure for sickle cell disease at this point in time.
As I said earlier, that's a lot for a parent.
Yeah. It's unfortunate that they spend much time at the hospitals or the clinics all the time. And like I said, sometimes they have more children in the family or extended relatives who have the same situation.
So you mentioned when you were talking about the treatment options and preventative care, transplant. So talk to us a little bit more about transplant for sickle cell disease. What makes a patient eligible, or what would that kind of evaluation be for a patient?
We started doing transplants about 25 years ago or more for sickle cell disease. And it used to be candidates had to have severe symptoms of sickle cell disease, such as stroke, several episodes of acute chest syndrome, recurrent pain episodes, or damage to major organs to have a transplant. But now patients are being treated with transplant who have less severe symptoms.
What would make someone eligible for a transplant?
Now, aside from having the severe transplant where they have very severe symptoms, others would be just being in the hospital a lot or altered quality of life. There's a lot of studies that are open for transplant and sickle cell disease, and they may fit the criteria for many of these studies.
So is this a more common option for patients that have a sickle cell diagnosis?
It should be, but still there's many patients out there with sickle cell disease who would fit the criteria for transplant, but are never referred to transplant centers to be evaluated to have a transplant.
So now I'm going to ask you to walk us through the steps. You have a new patient who has been diagnosed and is coming in to see you all for transplant workup and what the next steps are. Can you talk about that with us?
Yes, usually they're referred to our center or other centers to be evaluated if they're an eligible transplant candidate. Sometimes they're self referrals, and sometimes they even come from other countries in the world to the United States to have these transplant evaluations performed. So the ideal candidate for a transplant for sickle cell disease is usually a matched sibling. And those were what the early studies were for bone marrow transplant. But not many patients have a matched donor. Therefore, more and more studies are being conducted using related haploidentical donors, matched unrelated donors, and more recently, gene therapy, in which the recipient's own marrow is genetically modified. It's not uncommon for the donor who is picked for the transplant recipient to have sickle cell trait. That's okay. But they may not have sickle cell disease. And then once that patient who received a donor that was sickle cell trait, they'll just become trait positive. The next step is once they're determined that they can have the transplant, a pre-transplant organ evaluation is completed. It's very similar to what's done for malignant transplants, but it also includes checking for antibodies to blood products because many of these patients have received lots of blood products and may develop antibodies to either the donor marrow, the platelets, or the blood transfusions they require. Also, we'll evaluate their liver for presence of iron because of their multiple transfusions they receive. And we'll do MRI, MRAs to evaluate either their liver or their brain structure and see just how the integrity of the vessels in the brain or the liver are intact. Also, we do fertility preservation consult in case they want to preserve their fertility because sometimes some of the chemotherapy given makes them unable to have children. Once they pass this pre-transplant organ evaluation, then they're ready to start their prep reg. The prep reg is usually determined by the type of donor or if they are enrolled on a study. Many sickle cell disease transplants are on study, especially for haploidentical, unrelated donors, and gene therapy. That is the recommended standard of care. Now studies are looking at reducing regimen-related toxicities, so mucositis, infections, number of transfusions, and day 2 engraftment with promising results.
That's great that there are those options. And it's interesting. I was just actually wondering when you were talking about the sibling donors and family member donors, with this being a genetic disorder, I was wondering how that would work as far as, having a match and knowing how those matches work in transplant, that there could be a chance that you would have a complete match, but there may not be a chance. But I was thinking about that whole genetic piece of the sickle cell disease and how that would play out.
Yes, it's good to know that they are able to have their MATSIB as a donor if they're trait positive. That opens up more donors to them.
That's really good to know. So, does transplant for sickle cell disease differ from transplant for other hematologic malignancies?
Yes, it does. And probably the biggest part is just education of the patients and families. When they come in for a malignant transplant, they've usually already have had lots of chemotherapy. They understand the concept of chemotherapy and its side effects. They understand counts and just all the isolation that's required when they're immune compromised. These families do not know about any of this. So intensive education needs to be done so they understand all the precautions that are needed when you're profoundly immune compromised. Other supportive care that we need to do with patients with sickle cell disease is the fact that many of their organs have already been damaged or are compromised because of the sickle cell disease. And so they're at increased risk for liver problems, pulmonary problems, CNS, cardiac, and other toxicities. So we need to be very stringent in our supportive care for these individuals. Also, the multidisciplinary team is a little bit bigger when you're taking care of patients with transplant for sickle cell disease because you need more input from the hematologist because of transfusions and antibodies they may have developed before they came to transplant. A lot of support from the blood bank and those physicians, as well as just psychology. Because they've had strokes, you may have to do pre and post neuropsych evaluations to help you determine what their neurostatus and their neuropsych status is and help them assimilate back into society once they're completed their transplant.
A lot of things that have to be considered, that's for sure.
Yeah, it takes a village, basically.
So let's talk about some of the possible complications of stem cell transplant and what some of the solutions might be for them.
Some of the common side effects are veno-occlusive disease, or as they call it, SOS, a lot nowadays. And that's because they've had so many transfusions that they may have damage to the liver from iron overload. So they're at much higher risk for VOD. Seizures, because of their CNS blood vessels may be altered. Stroke and hypertensive crisis. And then a very common thing we see, unfortunately, is posterior reversible encephalopathy syndrome, also known as PRES. We see it in regular transplants, but it seems to be increased in individuals who had transplant for sickle cell disease, and most likely because their vessels are altered in their brain. And PRES presents as like seizures, changes in their consciousness, headaches, visual abnormalities, nausea, vomiting, or some focal neurosigns. And we have to act on PRES immediately because that can be very devastating to the CNS. Other issues they have are pulmonary insufficiency because they've had many episodes of recurrent acute chest syndrome. So we have to be very stringent in how we do pulmonary toilet, albuterol, and other things to maintain good perfusion in their lungs. Some of the solutions for complications of these side effects are supportive care. In addition to the traditional supportive care we do for patients with malignant transplants, nurses must also do strict monitoring of their blood pressure. By maintaining rigid blood pressure parameters, we are able to prevent seizures, strokes, or PRES. Also, because they've had a history of strokes, and sometimes they've even had numerous CNS bleeds before they come to transplant, we maintain their platelet count greater than 50,000. Typically, in malignant transplants, we do 10,000, but we want to keep their platelets greater than 50 to prevent CNS bleeds. And what we usually have to do is make sure there's a good supply of platelets in the blood bank all the time, because they may receive platelets more than once a day. And we'll check their platelet counts maybe twice, 3 times a day. Another thing with sickle cell transplant is we try to keep the serum magnesium around 1.5, 1.7. Some centers even like doing 2.0. Because that also helps to prevent seizures. So these 3 things are very important differences in sickle cell transplant versus non-malignant transplants. So I'll repeat them again. You want to do rigid blood pressure management. You want to keep the platelets greater than 50,000, and you want to keep the serum mag somewhere between 1.5 and 2.0. Those are probably the major side effects that you can avoid by having solutions such as good, strict supportive care.
Well, thank you. I think that's a really good start for folks who might be new to even understanding transplant for sickle cell disease, or new nurses going into pediatric oncology, and just some good things to remember.
Yes, it's like in the early days of the initial study for transplant and MATSIB, the physicians would all go around and repeat, I would almost call it like a mantra, platelets greater than 50, magnesium greater than 2, and blood pressure controlled.
Good things to keep in mind at all times.
Yes.
So what is the success rate of stem cell transplants in pediatric patients with sickle cell?
Well, in the early studies published by Walters in 2010, there were excellent outcomes with MATSIB transplants. About 93% of them survived, and 85% were cured of their sickle cell disease. And they had excellent organ function stabilization after recovery from transplants. And also the study results could be repeated worldwide. And there was a low incidence of some long-term sequelae. And it looks like quality of life appears to be good, but of course, more formal studies need to be done. Now, on other type of transplants, the haplo and the unrelated, it's too early for me to really give data about what the success rate is. Also, that would include the gene study transplants.
Well, that's definitely some positive news and some, good outcomes, and things can just continue to get better as we improve, and whether it's, our diagnosing or the treatment options and things like that improve. That's wonderful.
Yes, it's very exciting, especially because I've been doing transplants for patients for sickle cell disease since the studies opened. It's so much fun to have a parent come back and say, I can't believe they don't have any pain anymore. Or, they used to have to get transfusions all the time, and their hemoglobin is like 14. And, the parents are like, I can't believe they don't need any transfusions anymore. You can just feel their energy, and it's just so exciting.
That has to feel really good, being able to see those parents and knowing, kind of from where they've come, and to get to that point, like you said, that just has to, be a wonderful feeling all around for, the village that got that child to that place. It's so exciting.
It's very exciting, and it's exciting to see my patients 20, 25 years later out there in the world in very successful jobs. And it's just very exciting to see that.
Okay, so Ellen, we've just talked about transplant and, just kind of the process of it and the differences from hematologic malignancies and sickle cell disease. But now let's talk a little bit more about a couple of other things with transplant. So when pediatric patients are getting ready for their transplant, they receive chemotherapy and other medications and treatments to help their bodies accept these new stem cells. But sometimes that doesn't always work. So how often do patients reject stem cells?
It's difficult to give specific numbers because there's several types of donor transplants currently, and ongoing studies are also being conducted. Rejection is greater in donors that are partially matched related, unrelated, or cord blood. Rejection risks are related to the status of the patient's immune system. We see increased risk of graft rejection related to strong immune systems pre-transplant, if they've had a history of chronic transfusion and exposure to a lot of alloantigens, and development of autoantibodies, microenvironment of the bone marrow, or less marrow space because expanded erythropoiesis, all are causes of rejection. To avoid rejection, drugs such as APGAM have been added to the preparative regimen. Many times we see mixed donor engraftment, and unlike malignant diseases, this is associated with success. We do not need 100% donor engraftment with sickle cell disease. Mixed chimerisms can eliminate sickle cell disease symptoms and also maintain low hemoglobin S levels so they no longer have sickle cell disease complications.
Well, that's interesting. When you were talking about the mixed donor cells and the mixed chimerism, that's really great because normally, or unfortunately, in malignant diagnoses, when that happens, then that means that their disease has not been completely eradicated and causes more problems. What are some of the complications that might arise because of rejecting their stem cells, and what's some of the nursing management strategies?
Probably one of the unfortunate is they have return of their sickle cell disease and all the complications associated with sickle cell disease. Others, they may not re-engraft their bloodline, so they may need transfusions of platelets and red blood cells. Usually, we go ahead and evaluate them, see if they're willing to try another transplant, meaning a boost from whoever their donor was, to see if that will work. But it is very unfortunate that their sickle cell disease returns. And so the basic principles of nursing care for sickle cell disease would need to be there, as well as a lot of support from psychology to help them deal with the fact that their transplant was rejected. And this may also include, if it's a matched sibling, the donor may feel like a failure, especially because they're a sibling, and they may think it was something they did wrong.
That is definitely a hard part if the marrow would not take or engraft and it was a sibling. And that kind of brings up something that I've been thinking about in a couple of your other answers, and just talking about, it takes a village and, all the things that have to be considered with these kids. And something that I wanted to ask you is, are there a lot of ethical dilemmas that happen in transplant with sickle cell disease children that you have noticed, or that you've been part of those difficult conversations?
That's an interesting question, because in the early days of matched sibling transplant, every time a patient was a candidate for a transplant for sickle cell disease, an ethics board would review the entire case and determine if they were definitely eligible to go forward with the transplant and that the family and everybody felt okay with the transplant. Now, usually for mat-sib transplants, we don't see that typically needing to be required. But when we're doing transplants for unrelated and also for gene therapy, many times ethics will be discussed about that because that is more new and innovative. And as we know, with unrelated transplants, the risk of toxicities such as graft versus host disease especially is much greater. So you got to look at the risk benefit of doing the transplant. Also, there's a big cost factor in whether it will be covered by the third-party payer, how much money the family would have to pay out of pocket, and also compliance or adherence with the entire therapy, because it's so different from people who have malignant transplants where they understand more about the chemotherapy, the blood counts, and the immunosuppression, and the amount of time it takes to recover.
Thanks for answering that. I think that's definitely, like you said, one of the differences between malignant disease and sickle cell disease and just the experience of those long-term treatments and things like that. So now that we've talked about kind of how a patient is diagnosed, we find out they're eligible for transplant, they have their transplant, and the transplant was successful. What is the nurse's role in coordinating care for long-term follow-up?
One of the biggest things still is just education. You have to educate them about side effects and supportive care, and also just adherence. Adherence is just very essential to a successful transplant. Transplant's not trivial, and non-adherence has been identified as a concern for transplant, especially in sickle cell disease, because they don't have the understanding of all the concepts the way patients with malignant transplants do. And of course, it can result in negative outcomes if they're not taking their cyclosporin or tacrolimus, and they develop graft versus host disease, which could evolve into chronic graft versus host disease. So we need to make sure education and understanding and adherence to the treatment plan and supportive care remains. As far as long-term side effects, there's always fertility issues, and we try to address that upfront by preserving their fertility prior to getting the chemotherapy. They need to follow up with scans and other labs because they've already have had damage to their lungs or CNS prior to transplant. And we know transplant may cause further issues, so we always want to make sure that they follow up with scans and labs. Counseling them about a very healthy lifestyle, especially because they may have already had impairment from their sickle cell disease before transplant. Educate them about the late effects and just even the genetics. Like I said, a donor could be sickle cell trait positive. So, of course, if this person who had a transplant had a child with someone else who was sickle cell trait positive, they always could result in a child with sickle cell disease. Also, psychology and that neurocognitive status needs to be evaluated on a regular basis so we can help them get to a new normal and function in society.
Well, Ellen, I want to thank you for being with me today. I have learned a lot from our discussion, and you definitely have been involved with this patient population for a while and have seen the treatment options and how it has progressed. And, just hearing you talk about being able to see those kids later on who have had successful transplants has been really neat. As we're coming to the end of our time today, I have some questions that I like to end all of the podcast on. So we're going to go quick fire and ask you some of these questions as we finish up. And the first one is, what are common misconceptions about stem cell transplants in pediatric patients with sickle cell disease?
That it's very experimental and like a last-ditch effort. The fact is that the annual number of transplants has quadrupled in the past decade for sickle cell transplant.
That's amazing. What's something about stem cell transplants that are not often discussed, but you wish people knew more about?
That sickle cell transplant is the only cure for sickle cell disease. There's a lot of people out there who are eligible for it, but there's less people who are being transplanted. And I definitely would like people to know that transplant is a cure.
That is definitely an important piece to take home from this podcast. What additional training or education do oncology nurses need?
Probably the biggest is at the institution level, lectures, classes, hands-on preceptorship, and then attending conferences or other social media that, like this podcast that would educate them about sickle cell transplant, as well as professional organizations, going to conferences, doing virtual conferences to learn more about transplant for sickle cell disease.
And lastly, what are some additional resources for patients and providers who want to learn more about pediatric sickle cell disease and stem cell treatment?
Your hematologist may have knowledge. The local comprehensive transplant or sickle cell disease program. One of the biggest ones is Be the Match program. You can go online and learn a lot of information about sickle cell transplant. It keeps getting bigger and bigger, the information Be the Match has. NIH.gov or CDC.gov also have a lot of information, and sicklecelldisease.org does. But one thing I find very interesting is a lot of my patients want to talk to somebody who had a transplant for sickle cell disease, and they seem to think that is one of the best ways, too, that they can find information. So I would recommend it for nurses also. Talk to people who have had transplant for sickle cell disease.
Well, again, Ellen, thank you so much for being with us today and for your vast knowledge on this topic. It is just so helpful. Do you have any final comments for us today?
Yes. Although transplant can be a cure for sickle cell disease, vigilance must be maintained all the steps of the process because the side effects of transplant could be worse than sickle cell disease.
Thank you so much. We appreciate having you.
You're welcome.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.